Both the two expert moderators, Manoj Monga for the stone cases and then Curtis Nickel for the chronic pelvic pain, have got a selection of slides. I'm encouraging them to use them, to quiz the three experts, to have a debate, but we're going to do it by the clock, so there's no pressure to finish all the slides. We'll take the cases as they go. So the first set is a case discussion on stones. Moderator Manoj Monga, who gave us a fabulous dissertation earlier on ureteroscopy. And our three BAUS panelists are all experts: Darren Smith from UCH London, Anthony Timoney from Bristol, and David Tolley from Edinburgh. So Manoj, over to you. Thanks.
Well, thank you very much, President Bonart, President Speakman, members and guests. Thank you for the opportunity to start off the joint AUA BAUS symposium. So first, my apologies to Professor Dam and Professor Gupta. I'm going to be taking you all the way from evidence-based medicine back down to expert opinion. We have a wonderful expert panel here, Professor Darren Smith from London, Mr. Anthony Timoney from Bristol, and Mr. David Tolley from Edinburgh. We'll jump right into our first case. We have a 37-year-old gentleman with right flank pain. He's a first-time stone former, seen in the emergency room. His pain is manageable on oral analgesics. He has no infection, stable vital signs. His BU and creatinine are normal. His urinalysis looks pretty clear, except for some mild microscopic hematuria. So we'll start by asking who's going to get an ultrasound, and maybe I'll ask the audience, ultrasound? CT? So apologize for the New England Journal. Clearly we haven't been convinced that ultrasound should replace CT. I guess the question boils down to the question that Mr. Smith presented was that the amount of imaging would decrease if you could select who to image, but if you see hydro, you need a CT to determine why there's hydro. If you don't see hydro, you need a CT to figure out why the patient's having pain. Any comments, Darren? You had the opportunity to review that article fairly carefully. Anything else you'd like to add to that?
No, and we were chatting about it outside afterwards. For the first time patient, I think what we want is a diagnosis, so that what we can give is a decision and a plan. I think where we can be more judicious in the use of the imaging is in follow-up patients, and we've all got people that we can remember who've come through our A&E departments, who've had a CT scan that was normal, so they don't have stone disease, they don't get a diagnosis for their pain, and they turn up there again 3 weeks later. That sort of patient ends up having another CT scan and another CT scan and another CT scan, and if you did an ultrasound in those and showed that that was undilated, I think most people would say that you could have saved 3 CTs in that individual.
Thanks. That's exactly the role for ultrasound and follow-up in patients who've had a recent CT scan. So this is our gentleman's CT. We see some hydro there on the right, and this is the cause, a 10mm stone in the proximal ureter. Helmholtz units 950, skin to stone distance 12. It's visible on KUB and fluoroscopy. Let's maybe make it a little harder and pretend that this is a 5mm stone. Mr. Timoney, alpha blocker or no alpha blocker?
Well, no alpha blocker.
Everyone in the audience, if you could raise your hands, would you try an alpha blocker if it was a 5mm stone?
Not after the day.
I would have done before this morning.
So it sounds like everyone's convinced by this excellent article in the Lancet. And Philippe, maybe I could ask you, so you were part of kind of the Cochrane review was part of the meta-analyses, one of the 2 major meta-analyses, and so do we discard all that information now that we have a well-designed prospective randomized clinical trial, or is there any controversy remaining in your mind?
So I think I showed you a slide where I said that on rare occasions should we judge our clinical practice on a single study alone, and I think there's a point to be made here. There are actually 27 studies that have suggested that there might be a benefit. Now we have one very well done study that suggests there's no benefit. I've been strongly encouraging the authors of the Cochrane review from 2014, which are in a very good position to update their review to put this into context. And I would like to see all this data put together before I change my practice. So I am inclined still to give alpha blockers because I also think that and I'd love to hear from the audience, they're well tolerated and they're not expensive.
Well, now that I have your back, I'm going to raise my hand that yes, that 5mm stone I would put on an alpha blocker, and it'll be interesting to see perhaps what the reanalysis by your group will show us. So getting back to the story, this is a 10mm stone in the proximal ureter. So let's see, Darren, would you go with ureteroscopy or shockwave for this patient?
So we judge our decision based on the stone, its hardness as you have got there, sometimes the renal anatomy, what the access is going to be like, and then on the rest of the patient.
I'm sorry, I'm going to cut you off and just ask, shockwave or ureteroscopy? Because...
shockwave.
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 Anthony?
Yeah.
David?
Shockwave.
Shockwave. Audience, if this was you, shockwave or ureteroscopy? Who would say shockwave? And who would say ureteroscopy? The ureterospist, if you were the patient, would you keep your hand raised? You would, okay. Thank you.
So in our hospital, he'd have what we call hot lithotripsy, where he'd get lithotripsy within 24 hours.
Yes, exactly. And so there has been one randomized clinical trial suggesting that if one treats within 48 hours, outcomes are superior both in terms of stone-free rates and the requirement for secondary procedures. So it's nice to hear that you do have that flexibility at your institution, I think. So we've already discussed MET. Shockwave was recommended by everyone on the panel, as well as about 2/3 of the folks in the audience. Ureteroscopy and PCNL. David, what would be your criteria for PCNL for a proximal ureteral stone? Is there a size criteria or other considerations that you might try?
I'm bound to say it would be our last choice. And I think, again, that's based on evidence from within the department. We've kept our audit since 1987, since we first developed the centre. So we've got a pretty good idea of what actually works in our department, in our hands. And I think it does depend what equipment you have available in your own department, but most importantly of all, actually what the patient wants. So you might, for example, say, well, the chances with PCNL of getting as close to 100% stone-free in one sitting is the best of those 4 treatments. But on the other hand, it's a highly invasive procedure, or relatively highly invasive procedure. If that's absolutely what your patient wants when you've been through all of the discussion with him or her, that's okay. But we know that with certainly shockwave in our hands, within 24 hours of presentation, we can get up to 90% stone-free rates for a 10mm stone. And similarly with flexible ureteroscopy, you're going to get, and laser fragmentation, you're going to get similarly very high stone clearance rates. The choice ultimately comes down to what suits the patient and what works best in your department.
So I show this slide just to show the intersection between evidence-based and shared decision-making. And though the evidence base shows us that for a 10mm stone, or greater than 10mm stone, ureteroscopy has higher outcomes, better success rates compared to shockwave, this difference of 15% really isn't sufficient to change a patient from doing something less invasive to more invasive. We found that when we look at how patients actually make their decisions, that difference needs to be 50% for every patient to choose ureteroscopy. Between 25 to 50%, about half of the people will choose ureteroscopy and half the people will choose shockwave. But if this difference in outcomes is less than 25%, almost everyone will choose shockwave as the primary modality, just as you the panelists in the audience did.
But we have a conflict of interest, though, I think, because we've all got in-house lithotripters.
Yeah, I was going to make a similar point. It's all very well saying we'll go for shockwave lithotripsy. If you've got to wait 2 weeks to get onto a machine, which does happen in some parts of the NHS, then you may well say, actually, I'd rather have a flexible ureteroscopy because it can be done on the next available list. So I think choice is, or the availability of treatment is actually very important in decision making within the confines of the system that we work in.
Well, those are very important considerations, and I would maybe allude to that also, that if one needed to do something within that 48 hours because of symptoms, then certainly a primary ureteroscopy as opposed to just stenting the patient may be optimal. Darren, if we were to say that you were going to do shockwave, we've talked a little bit about how trying to do it early within 48 hours is optimal. What type of anesthetic do you like?
None.
David?
None.
None. Anthony?
None.
Is everyone doing shockwave without any anesthetic? And what, by none, do you mean no sedation either?
Yes, I mean no sedation.
Yeah.
So we offer the patients an option of PCA with alfentanil for the nervous patients, but only about 17% of patients get it.
Okay. So I think now I understand what the stiff upper lip means.
You've got to draw this distinction between analgesia and sedation, and the two are not the same.
Yes, yes.
So I think we would all give the same alfentanil as analgesia, and in an adequate dose, because if you don't, the treatment is more likely to be ineffective. So you've got to make sure the patient is well looked after and has an appropriate amount of analgesia.
Yeah, we find a similar experience that in well-selected patients, just a milligram of Versed and 50 of fentanyl works very well for the complete procedure. Stent or no stent? Who in this patient would place a stent, assuming that you had accessibility to the shockwave machine within 48 hours? Good. So it sounds like everyone's on the same page that a stent should only really be used to temporize measures, not necessarily to help decrease the risk of Steinstrass. Again, the theory would be if you have to instrument and place a stent, perhaps shifting the plans and going with the ureteroscope as opposed to shockwave would be a good alternative. Anthony, gated or ungated?
Ungated.
Ungated. Anyone treating gated or everyone treating ungated?
Only with breathing.
Fast or slow?
Well,
Anyone
we're in
treating at
between.
120?
120.
90?
Yeah, we're at 90.
60? So nice randomized studies suggesting that 60 is better than 120, 90 is better than 120, no significant difference between 60 and 90. Because most patients' heart rates are around 60 to 80, I'll treat everyone gated as opposed to ungated. Because that way we're achieving the slow rate and also decreasing the risk of arrhythmia. David, comments?
Not really. I mean, I think it's in practice, the great temptation for most people is to get on and treat at 120 because you finish the treatment more quickly. Sure, I get why you should treat at 60 or 90. But I think in the real world, in a number of centres, people still treat at 120.
Anyone who's treating slow, Darren, do you tailor it to the size of the stone or location, or is it all comers that you'll treat at a slower 90 rate?
No, we treat them at the same rate. I mean, we've seen the data, and it is quite convincing. But we have that same sort of practicality of approach that if you treat at 60 as opposed to 120, it takes twice as long. We're not giving sedation in the patients, so we've made the pragmatic decision that around about 90 is the right sort of rate.
So question for the audience, how many people pause after the first 100 shocks for 3 minutes, with the concept being renal vasculature, constriction, decreased hematoma, decreased injury to the kidney? Anyone pausing for 3 minutes? It looks like they're not convinced. Anthony, are you convinced by Dr. Lingeman's data that this can decrease the injury to the kidney?
Well, we don't pause for 3 minutes.
No. Darren?
No, this is from work in pigs, isn't it? With vasoconstriction being renally protective, but we don't.
David?
We ramp, but we don't pause.
Yeah, we ramp too. But I think you've got to draw the distinction between treating a stone in the ureter, where there may be no passage of shockwaves through the kidney, and treating a stone in the kidney. And again, the evidence in your own department from follow-up about the damage that occurs particularly in terms of hematoma. And I'm bound to say, and I think it's partly because we all treat with analgesia and not with anesthesia, that we all ramp up. So in other words, start with low energy and build up to maximum tolerated energy. And our incidence, well, we know because we measured it, is extremely low in terms of hematoma.
Yeah.
Would you agree with that, Anthony?
Yeah.
Most contemporary series probably from London, Ontario, saying that it's about 0.3% with the newer machines. Yeah. So thanks for covering this next topic, ramp up. It sounds like all three panelists are doing a ramp up audience. Are you starting at a low energy and gradually increasing? So some of you are, and for those of you who are not, the theories, number one, are decreased renal damage, number two, improved efficiency of fragmentation. So consider starting at a lower energy, 18 kV, and gradually ramping up every 100 shocks. So alpha blockers fallen out of phase for medical expulsive therapy. Does that mean no longer a role after shockwave lithotripsy? Darren?
Well, we aren't routinely, and that's not, and we've not been routinely, not subsequent to the suspend paper, but just organisationally knowing exactly when the patient is going to have their shockwave treatment and having them start it around the time of the treatment is actually something that can be quite difficult for some London-based patients to take on board. So we've generally not done it as a matter of routine.
Interesting, we were talking about it on Tuesday. We have it in our protocol, but we don't do it.
Change the protocol.
So follow-up, first in terms of timing. 1 week, 2 weeks, 4 weeks, 3 months? David?
It's routine in Edinburgh for them to get an immediate post-op KUB because we found that has helped with our management. Part of that is because we treat patients from outside our own catchment area. So in terms of organising follow-up, and again we have the luxury that we're able to remotely organise follow-up for patients at 1 week, 2 weeks, 4 weeks. So sometimes it's variable based on the immediate post-op KUB, and very often with ureteric stones, and I think we need to remember we're talking about ureteric stone follow-up here, you get very good evidence of fragmentation on that immediate post-op film, and it allows you to give the patient, I think, fairly strong advice that the likelihood of success is high, and you arrange a follow-up. Our follow-up would be 2 weeks.
Immediate is in the recovery room?
Well, yeah, we have the luxury of having a lithotripter suite, which has its own standalone X-ray facility. So we can take the patient off the lithotripter, they get changed and they go through and they have a KUB. So you can do KUB within 5-10 minutes of the procedure. And
has that been published, the outcomes based on that immediate KUB in terms of need for secondary procedures or stone-free 1 month later?
I'm not sure we have published that.
Because that might be a really nice addition for the rest of us. Appreciate it. Thanks. So we alluded also to the idea of treating earlier within 48 hours, decreasing the risk of secondary procedures, decreasing the time to stone passage and so forth, with the idea that perhaps we're avoiding the ureteral edema that could preclude stone passage and successful shockwave. So now we'll switch gears and pretend that everyone said they would do ureteroscopy and talk a little bit about technique. Darren, what's your first wire to use?
Sensor.
David?
Sensor.
Anthony?
Cheap and cheerful, little, just the ordinary green wire.
Okay. So how many people in the audience?
If I had any difficulty passing the wire, I'd change to a sensor immediately.
Oh,
If it just slips in, I will use a green wire, because it's only a £5, whereas the sensor's about 30 quid.
Can I ask Anthony a question can I challenge you on that, Anthony? Because one of the big concerns here, of course, is that stone maybe looks impacted, that particular one we're talking about, but I think if we'd all remember the cases where we passed a straightforward wire and the stone's gone popping back into the kidney. And I suspect the reason that both of us said a sensor wire is because of that flexible tip that just slips past the stone quite nicely.
I agree, and for a slightly different reason, rather than that sort of snooker cue and pop the stone back into the kidney, that your first go is the best go. And we've all been, astonished really when you get the scope up and you see what it looks like, just how relatively straightforward it was for a sensor wire to get into the kidney. And if you go up with a green and it is a bit stuck, and either you make it bleed so your view is poorer, or you even perforate with the green wire, then you've taken a step off the path straight away. So we would use a sensor as the first wire.
And so I don't know if in the U.S. you have the credit card ads where they talk about how something is priceless. And certainly the ureteral perforation, that's priceless. So you can't put a number on that. And though a sensor wire, at least in our shop, is about 4 times the cost of a regular wire, the question is if it's a more reliable, safer wire. But that might be an area where really there isn't good data to say if you use a Benson or something less expensive, how often do you really run into trouble, and how often would it have maybe been easier, safer, more cost-effective to start off with the sensor? Anthony, it looks like you have a
I would accept I'm an outlier on that, because the trainees coming through all use sensors.
Yeah. David, do you always start with a retrograde, or only if you run into trouble?
Frankly, it depends, but it's nice to put just a little bit of contrast up. Again, the paranoia here is that what you end up doing is changing what is a straightforward procedure into a difficult one, because Sod's law is, what may happen is that the stone pops back into the lower calyx, which is exactly the calyx you don't want it to be in.
Right.
Sometimes some
So
contrast,
two issues
but not
are
very much.
migration of the stone. The second is increased radiation. Anthony, what's your practice?
I don't tend to use retrograde.
Darren?
I'd put a ureteric catheter through the cystoscope with the sensor preloaded, get a bit of better purchase just underneath the stone. If the wire goes past, brilliant. If it doesn't, the wire comes out, and then you've got the ureteric catheter right there and do a retrograde. So maybe not.
Exactly. So it sounds like predominantly selective use of retrogrades. How many in the audience always start their ureteroscopy off with a retrograde? So the next question is retropulsive devices. David, do you use any retropulsive devices?
Not routinely, because again, I think in this situation, there is always the risk that when you try to pass anything past that stone, it'll shoot off into the collecting system. What I would do before starting is actually to adjust the position of the patient on the table, and we would always start up in a head-up position, so that the chances of that stone migrating upwards with the aid of gravity is reduced. And our anaesthetists are actually fairly good because they'll allow you quite a lot of latitude, quite a lot of head up. And again, there's no evidence, but it certainly makes me feel more comfortable.
Well, those are excellent points. And really, the utility of an anti-repulsion device is if you have a large impacted stone and a fair amount of hydronephrosis. But that's also the setting where you're more likely to perforate. So passing two things, a safety wire and an anti-repulsion device, is now doubling your risk of perforation. So I agree with you that probably its utility is fairly low. Anthony, sheath or no sheath?
I never use a sheath.
Never, ever.
Ever. I'm thinking about it, but...
Darren?
Well, for this case, no, because my instrument of choice would be a semi-rigid ureteroscope if I could get it up to the stone. And then if I couldn't, then I would see how the ureter looked, and then I would consider putting a sheath up if I was going to retrieve. If the ureter looked fragile, I'd just put a flexible scope into the kidney, and then I'd be a duster.
So let's take a poll of the audience. If the semi-rigid only gets to the mid-ureter, you can't get to this proximal stone, how many would place a sheath before proceeding with the flexible scope? Anthony? David?
Yes.
Yes, okay. Good.
And also, remember, this is a 37-year-old man, so he's likely to be quite muscular. Now, my guess would be it's going to be much less likely to get there with a semi-rigid. I mean, I agree, Darren, that very often you can get there with a semi-rigid and the view's better, particularly if you use a twin-channel semi-rigid. And in this situation where you've got a complete blockage of the ureter. But I think using a sheath, particularly if you need to do a bit of ureteric dilatation, you've got a system where you're effectively turning your flexible ureteroscope into a twin channel, because you're getting a flow of irrigant up to the stone and then down. And again, it's subjective, but I think it just improves the vision. So I would use a sheath and a flexible scope.
So I think the consensus from the panel with one dissenter is start with the semi-rigid. If you can't get to it, switch to the flexible scope, but use a sheath if you do flex. And Anthony, maybe you'll switch at some point.
Well, I mean, you wouldn't put a 12-14 French scope up. I know a sheath isn't the same thing, but I just think they're very large. And the whole process of miniaturization is uncoupled once you start using a sheath.
I just come back to that because 3 or 4 years ago, Anthony would have absolutely agreed with you on that. Firstly, you can use a 10-12 sheath, and with a smaller ureteroscope, flexible ureteroscope, I think the risk of causing trauma to the ureter is far, far less. I think with a little preliminary dilatation too, you're less likely to get the radial tears in the ureter. So I think overall you're probably minimizing the risk of any form of ureteric injury by using a small sheath. And I'm a convert. I'm bound to say 5-6 years ago, I too would have said not under any circumstances, and I've completely gone the other way.
So we'll take a poll of the audience. How many of you are dusters? And how many break up the stone and basket the pieces? Okay, good. So it looked like, Darren, you're a basketer. Anthony, were you a duster?
Duster.
A duster?
Yep.
And David, duster too. Okay. So we showed some preliminary data from this trial saying that dusting 30% of patients will have significant residual fragments. Do you think that doesn't reflect your practice, or is it something maybe we need to look into a little bit further?
Well, I would, first of all, never use a basket in the ureter. We'd use a triradiate grasping forceps, but never a basket. And this stone is in the ureter. So if we did do some stone extraction, it would be using a triradiate grasper. Or there's a device called N-Gauge, which I'm quite fond of. So we wouldn't take out pits with that, but otherwise we will generally in the ureter dust and then put a stent in.
Thanks. And I think your last comment was a stent, so that brings me to the next question. At the end of this case, the patient looks stone-free. The ureter looks pretty good. It was a little tough to get everything out. Stent or no stent, do you tailor it to location and size of the stone and kind of have a plan before the surgery, or is it always at the end of the case when you decide what to do? Darren?
No, this is a really important discussion to have had with the patient beforehand, particularly if it's a patient who's previously had a stent. If they have and they hated it, then the 50-50 decision where you can't make up your mind becomes extremely easy. I then don't put up a stent because I know that the patient is going to tolerate the pain that they've got afterwards. What I'd probably do is to put up a ureteric catheter. I know that doesn't solve the problem of edema at 48 hours, but what it does do is it means that when the patient is in recovery, you're not going to have somebody coming through saying, your last patient is in screaming pain. You can say, yeah, I know the situation is safe, and go and see them later and explain. So if they've had problems with a stent before, on their behalf, I'd try to avoid putting in one again.
And in that pre-op discussion, what do you tell them the chance of them coming back and needing a stent is the next day or 2 days later?
So for most of those that have a ureteric catheter in, when you make the decision that you're going to do nothing, they're absolutely fine. And some of those we've seen it even fall out and the patient's been fine and we've been overcautious. If there is any doubt, not the 50-50 decision, then of course you go for safety and you put a stent in at the time. Much better to take the patient back when they're already on the table than do it the next morning.
And how long are you leaving the catheter?
Just till the following morning.
Okay, so everyone stays overnight in that case?
They would.
They would, okay. Anthony?
Well, if the patient has previously had a stent, you probably won't need to stent them again because the stent causes a bit of ureteric dilatation and usually they're easier to do. If a patient says he doesn't want a stent, then they do get dusted. And I don't try ever extracting stone fragments from patients who said they definitely do not want a stent because they have previous experience of it. In the context of whether I stent or not, my registrar came to BAUS on Monday and she left me an email documenting the 3 patients that were admitted over the weekend because they had pain because I hadn't stented them. So, it swings in.
One of those was mine.
All right. Okay. Two are mine. One was Frank's. But the stent or not to stent question is a difficult one. We have a booklet that we give all the patients I give the patients prior to stenting. I'm not saying everybody does. And we try and get them out. The promise I try and make them is that I will take the stent out within a week or 2.
So 2 last questions for the panel. One for David. The question is, do you routinely image after uteroscopy? And if not, who do you selectively image? And then the last question for Darren will be alpha blocker or no alpha blocker with a stent. David.
Okay, well, it depends on the size of the stone you've been dealing with, the circumstances. So, for example, you've had to dust it or extract fragments. I think if you take out a stone in one piece, a small stone, you don't need to image them. When would I image? Well, if there'd been some upper tract dilatation, I'd want to be certain that dilatation had disappeared, wait for a couple of weeks, do an ultrasound. If I was concerned there were some fragments there and I'd left a stent in, then I would want KUB before removing the stent. So in other words, there's not a protocol, there are no hard and fast rules. I think it depends on the individual patient. There are many occasions when that patient is stone-free. There's been no upper tract dilatation, no need for immediate follow-up imaging, though of course if you're going to follow the patient up long-term because of risk of further stone formation, then a clinic review in 3-6 months and a KUB at that stage.
Darren, alpha blocker for stent pain?
Yeah, there are 2 meta-analyses that are in support of that, clinical experience is in support of it. And if you've made an active decision that the patient needs a stent, then it's always a disaster if it's removed too soon. It just reaffirms why you put it in the first place. So yes, I'm a believer. You've got to do anything that you can to manage the patient through those early stent symptoms, including letting them know that they generally get worse through day 1 to 4 and then start getting better. And it's not unusual that the patient has worse stent symptoms the day after you've put it in than the first day. So if they're expecting that, it doesn't come as quite such a shock.
Well, I'd like to thank our expert panel for your sharing your knowledge with us, and to the audience for your participation. And we'd like to invite Dr. Nichols to lead the next discussion. Thank you.